Hello, everyone. Welcome to the first affiliate hospital of Harbin Medical University in Heilongjiang Province, China. I am Dr. Cao from Cardiovascular Department. I am privileged to be the moderator of the current operation through MedStream 360 to demonstrate our theory and techniques in our daily PCI work. I hope each and every one of you will enjoy the following unique CTO case. Please allow me to introduce the leading first operator of today's case, Professor Li, whom is the leader of our hospital. Okay, next, let's begin our case. Dr. Jingling will introduce the general information of this case. Please, Dr. Jing.
Okay, I'm very glad to introduce this case. Now, the first operator is Professor Li. Now, the second operator is Dongguo, Wang Dingyu, and me. The moderator of today is Cao Yang.
Next. Okay.
Now, I will introduce the basic information of this patient. The patient is 49 years old. The patient is 49 years old with hypercholesterolemia for 10 years. 2 years ago, he was received PCI in right coronary artery for unstable angina pectoris. 6 months ago, he was chest pain and angiography at local hospital without any intervention. Next. Now these are the laboratory data. These data are negative. Next. The echocardiography shows sinus rhythm with TQT in lead AVL and V1 and V2. Next. Now the angiography shows the left circumflex is normal and the total occlude in LAD. Next. Now this, we can see left circumflex is normal. Next. In this angiograph, we whether if the LAD is the signal branch, the side branch, or the LAD total occlusion is true lumen. Next. The right coronary artery is normal and stand in the distal. Next. Okay, in this angiography, we can see the contralateral collateral in the RCA to RAD. Next. This angiograph shows two channels from RCA to RAD. Next. Now we can see these two channels. Next. Next, we'll invite Professor Li introduce QFR and other details for this patient.
Okay. Hello, everyone. So Dr. Jing already introduced the information of this patient. The patient last time implant stand in the RCA proximal and the middle portion, and the QFR evaluation showed the QFR is 0.84. Also, I think this time what we should treat the target vessel is LED osteocclusion. Next slide. Okay, from the angiogram we can see maybe proximal CTO cap ambiguity CTO lesion, but we couldn't make sure because we can from this way we can see 2 point A and point B, which one is the real ostim of the LED. We couldn't make sure purely based on the angiogram because last time they didn't do dual angiography. Next slide. So last time live demonstration I already show the special software we made. We call it uh, intelligent visualization system. That means based on the CTA, we use 3D reconstruction and artificial intelligence technique. We made this software we can easily to see the structure and the plaque distribution of the lesion. We can see the right one is aorta, the RC, and LED, and the circ, and we could easily to delete each of the component. Next. Okay, we already delete the aorta and the RC, and we can see really the green one is the circ, the blue one is LED, and the brown one is CTO segment, and the white one is the calcification. But in this case, we can see no white one. That means in the CTO segment, no calcification, just relative soft plaque. But from this, we can see, go on, next, next. Okay, we already delete the occluded segment. We can clearly see that really the ostim not at the point A should be at the point B. And just after the small side branch is the ostim of the LED, and we also can see a relatively clear stamp.
Yes.
So this we couldn't see just based on the angiogram. So this is a very important advantage of this software. Okay, next. Next. Okay, we can see very clearly. And please let Dr. Wang Dingyu to show us a live demonstration of this intelligent visualization system. Because we can easily to rotate in any direction. Okay, you can see first delete the aorta. Okay, delete the RCA. Okay, delete the stent. Okay, so we can rotate like in the RAO caudal view. Okay, Dr. Wang, show us the RAO caudal view. Okay, can you see the circ, the proximal segment, and the brown one is the CTO segment, and delete the brown soft tissue. Okay, we can see clearly. Okay, let's see the cranial view. Okay, cranial view to see the distal distribution of the. Okay, we recover the occluded segment, Dr. Wang. Recover the occluded segment. Okay, so I think we should choose the LAO cranial view. LAO cranial view. Okay, LAO cranial view. Okay, a little bit more rotate. I think should be in the opposite direction. Okay,
Yes.
rotate a little bit. Rotate a little bit. Okay, we already could see very clearly. So just in the middle portion of the occluded segment, there is a diagonal branch. Rotate a little bit, maybe cranial view. We prefer cranial view. Okay, cranial view. Okay, so we can see just at the middle portion of the occluded segment, there is a diagonal branch, but
Yes.
just based on the angiogram, we couldn't see. And the distal CTO cap is in the nearly middle portion of the CTO. So, okay, the length of the CTO segment should be more than 2 centimeter, and if we purely based on the angiogram, should be JCTO score 2.
Yes.
But if based on the CTA, maybe 1, because there is a relative clear step here. Let's see today's angiogram. So today we choose by a transradial approach. So as we know, in 2022 in China, about 1.3 million PCI cases, and about 96.9% of the PCI case was performed via transradial approach. And for the CTO, certainly we should choose by approach. For the left side, uh, we prefer to choose the distal transradial approach because choose the distal transradial approach, the patient may be more convenient,
Yes.
and the doctor also very convenient.
Yes. Yes.
But for the right side, commonly radio, uh, just a radio approach. But for the radio approach, we need to use seven French guiding system. So we choose uh, cylinder siege,
Yes.
glide
GSS.
siege,
Please.
okay,
Yes.
GSS siege. So the siege, the outer diameter that's like the six French, common six French siege, but could be advanced seven French
Yes.
guiding. Okay, let's see the today's angiogram. So firstly, we do the RC angiogram and use just Judkins Live to 3.5 guiding. So I think this guiding for the transradial approach, the backup support is stronger than common Judkins right guiding. And but one tips and tricks is a little bit to straighten the second curve of the guiding. So this guiding could easily deep seating, so could give relative enough backup support. And certainly, if the backup support is not enough, we also could use many other techniques like ankle balloon and Godzilla,
Yes.
etc. But another advantage compared with M plus guiding is Jenkins Live to 3.5 guiding is more safe. And why we first engage RC guiding, because RC guiding we need a little bit rotate. So first implant the RC guiding to angiogram. We can see still some lesion in the distal portion of the RC, but the QFR showed the FFR is 0.49. We needed to treat this time the RCA. And another tips and tricks, we should put a workhorse wire, a relative workhorse wire in the RC to make the whole system stable. And another function is the wire could help us to choose the critical channel. So we already know, Dr. Jing already showed the audience there are several critical channels from the RC to the LED, distal LED. So this is the RO view, but the RO view we can see didn't a very optimal view to differentiate the distal bifurcation. So we use should be RAO caudal view. So in this view, we can see very clearly the three distal branch could be differentiated. Okay, so next, this is the my earphone is still work?
Yes. We can
Okay.
hear you. Yes. Loud
Okay,
and
okay,
clear.
okay, okay. So for the left side, I choose BL3 zero guiding because for this gentleman, I found first commonly the left side radio approach is just like the common femoral approach. Commonly we choose BL 3.5, but for this case, we need to a little bit let the guiding toward guiding. BR30 still a workhorse wire in the third to keep the stable to avoid engage to the ostium of the LED cause the vessel injury. So do bilateral angiogram, and we can see just like Dr. Jing told there is a okay, no very clear stamp, no very clear stamp. Okay, so which one is the real ostium?
Yes.
We couldn't make sure, but certainly we could use IVUS to check the ostium of the IDD. But one limitation is the set branch is too small.
Yes.
Sometimes the common IVUS catheter couldn't be advanced into the okay, that's the other dual angiogram. We can see this should be the slide. We use IVUS to check the ostim of the LED, but just like me said, the IVUS catheter couldn't be advanced to the optimal place, so the transducer couldn't maybe see the real ostim of the LED. Okay, please show us IVUS.
I
Okay,
think it's run 3, right? I think it's run 3.
okay,
Okay.
okay. Show us IVUS. IVUS. Okay. So please allow Dr. Chao to interpret the IVUS, the first IVUS.
Okay, actually, just like the Professor Lee just showed us that the proximal side branch is quite small, so the IVUS catheter cannot engage to the proper distance that we can see the whole occluded vessel, proximal entry point especially. So this is the run. We can see that this is a relatively big proximal LED. However, since the catheter cannot engage to the right position, we didn't check the entry point of the proximal occlusion segment. So this is the first run from the proximal small set branch.
Okay, just uh, like we talked just now. So because the IVUS catheter couldn't be advanced to the optimal place, so from the first run we couldn't see the ostim
Mhm.
of the proximal LED. But one thing we can make sure, in the proximal portion, there is no
Yes.
the proximal fibrostic cap.
Yes.
But another tips and tricks, because IVUS couldn't be advanced further, another tips and tricks is for the IVUS catheter, sometimes we could cut off a little bit the OTW segment
Mhm.
to make the tip to the transducer shorter.
Okay.
Sometimes could be work,
Yes.
but this time still couldn't work
Mhm.
because after we cut off the OTW segment, the
Mhm.
crossability of
Mhm.
the IVUS catheter
Mhm.
decrease. Okay,
Yes.
so for such kind of case, okay, this is the angiogram showed that after we cut off the tip of the
Mhm.
IVUS catheter, the catheter still couldn't be advanced further.
But we advanced a little bit further
A
after we
little
cut
bit.
off the tip. Yes.
Okay, a little
Mhm.
bit, a little
Mhm.
bit. Okay. So so we according so in such condition, visualization is
Mhm.
very important
Yes.
because we already know that the proximal cap should be at the B point,
Mhm.
and
Yes.
there is a small step. We couldn't
Yes.
see just based on the angiogram.
Yes.
So because we already have this information, so this is very helpful for us to choose next step,
Mhm.
choose the strategy. So for this case, I use Cosea microcatheter and a workhorse wire. Have the microcatheter advanced to the proximal LED.
Mhm.
So this is the often method we use. And then we choose the wire based on the uh, intelligent
Mhm.
visualization
Yes.
because there is a stamp and there is no calcified lesion,
Mhm.
just a very relative short plug.
Mhm.
So we choose the field STA.
Okay.
So field STA is a hydrophilic taper tape wire
Mhm.
and sometimes could be used to cross the microchannel to
Yes.
loose tissue tracking. And we can see from the angle, so the field STA it could be relatively easily advanced a
Yes.
little bit further.
Mhm.
And then we advance a little bit the Cosea microcatheter to increase the backup support.
Mhm.
But we found the plug still have a resistance.
Resistance.
The
Yes.
Cosea microcatheter couldn't be advanced.
Mhm.
So I advanced a little bit further the field STA wire. Okay, we can see the Cosea catheter couldn't be
Mhm.
advanced, just the tip of
Yes.
the catheter. Such condition, different view is very
Mhm.
important
Mhm.
to get antigrade wiring. We can
Mhm.
see that times the wire should not be in the right direction
Mhm.
and withdraw a little bit and rotate the tips and tricks to manipulate this wire is just rotate
Mm-hmm.
a little bit, push forward,
Mm-hmm.
just let the wire go by itself.
Okay.
And because
Slide.
of the wire is very sharp, the feedback is not good.
Mm-hmm.
So we just to observe the tip of the wire.
Mm-hmm.
So to make the wire there is no large curve.
Yes.
So this is optimal manipulation, and you can see we are lucky, and the wire just
Mm-hmm.
like the CTA intelligent
Mm-hmm.
visualization show us relative soft block
Mm-hmm.
and where go to the diagonal branch.
Yes.
Really, the
The distal
diagonal,
branch.
okay, the diagonal branch.
Mm-hmm.
So then we use 1.0 balloon to dilate
Mm-hmm.
the CTO lesion.
Mm-hmm.
And because if we want to go manipulate the wire to
Mm-hmm.
the LED,
Mm-hmm.
we should still use the IVUS guide
Yes.
to find the ostim of
Mm-hmm.
the LED,
Mm-hmm.
to find the LED,
Mm-hmm.
the direction, and we can see this is a okay, the small balloon, 1.0 balloon,
Mm-hmm.
and then we did okay, we can see the balloon could be advanced freely
Yes.
and use the coaxial microcatheter to exchange a workhorse flare.
Mm-hmm.
So this is very important because
Mm-hmm.
workhorse flare is well received. And
Mm-hmm.
then we do IVUS.
Mm-hmm.
And please let Dr. Chao to show us the IVUS result, okay, from the uh, diagonal branch
Okay.
to see where is the LED, okay?
Okay, so actually there is a lot of teacher points that we can see. From Anterograde, Professor Lee has just made some progression to put the wire into the distal big side branch. And we make a pullback from the wire into the distal big side branch. So from this IVUS run, we can see that this working wire is in the intra-plug space of the side branch. This is actually a good news because we know that the wire is. However, we can see there is an intima at the downside of this vessel. And as we pull back, later we can see the main vessel of RAD joining into this vessel later. Okay, actually we can see here, this is a very big plug, controlator eccentric plug.
Okay,
Mm-hmm.
so the IVUS is very helpful to let us to find with the ostim of
Yes,
the
here.
LED. And in most condition, we light the transducer of the IVUS at the ostim of the LED, and then do an angle, and to help us to find the right direction of the LED.
Mm-hmm.
And then we use duralumin catheter. We also have a duralumin catheter, the Sasuke catheter, a
Okay.
very small profile
Yes.
duralumin catheter. And firstly use the field STA
Mm-hmm.
and the Gaia first
Mm-hmm.
and Gaia third.
Mm-hmm.
But we can see still couldn't easily advance to the distal LED true lumen. Yeah, okay. So we tried several times.
Mm-hmm.
Okay, so in such condition, really the IVUS guide is helpful, but
Mm-hmm.
for a hybrid operator, sometimes
Mm-hmm.
you should rapidly switch
Yes, to
the
stress lead.
strategy to
Yes.
save the time.
Mm-hmm.
And because sometimes also we could make the integrated wire advance, but if in the subintimal space, sometimes we may try wire-based or device-based ADR
Yes.
technique.
Mm-hmm.
So may for the LED, because there are several very important septal channel,
Yes.
septal
Mm-hmm.
channel patency.
Yes,
Or may
patency.
cause peri-procedure myocardial infarction.
Mm-hmm.
So we rapidly switch to the retrograde approach.
Okay.
And because we already know from the REO caudal view, we
Mm-hmm.
can see some septal collateral channel. And sometimes even we don't use super selective injection,
Mm-hmm.
the septal wire surfing also could successfully advance the thin wire to cross the septal collateral channel.
Okay.
But this time we did a super selective angiogram. We can see some collateral channel. And the first try, we can see the wire go to maybe some collateral channel, but not the optimal channel. And okay, I see the wire, okay, go not the optimal channel. And okay, this time, okay, this
So
time, hey,
it's
okay, this
serving
time
through.
success, okay, this time to the distal LED. Okay, should be the distal LED. And one tips and tricks should advance a little bit further the retrograde wear to give enough backup support.
Yes.
And then the Fancros microcatheter was advanced to the distal LED.
Okay.
But one tips and tricks to choose the retrograde wear is in such segment we can see with the heart
Movement. Yes.
movement, the wear movement significantly.
Yes.
So in most conditions, this should be a field STA wear. You can see moved significantly.
Yes.
Not a very good choice. We should choose relatively stiff,
Okay.
get wear, and we finally choose Gaia.
Gaia. Okay.
Okay, the Gaia wear. This is a super selective injection from the distal LED. And okay, this is we should advance antiquated wear and with the guide of the IVUS to make the retrograde wear escalation at occluded segment. But for this case, because we already know it's very soft plaque,
Yes.
so still the intelligent visualization gave us some guidance.
Yes.
So this time we directly use the retrograde wear to
go through. Yes.
go retrogradely. But one very important key point is we should use antegrade IVUS to check the retrograde
Position.
where the reentry
Yes.
point.
Yes.
If the reentry point is proximal to the third branch, it causes third branch loss.
Yes.
Because just at there is a big
Yes.
diagonal branch. The optimal place should be the retrograde where just come out at the carina of the
Occluded segment. Yes.
occluded bifurcation.
Okay.
And now we are ready. Advanced the retrograde wear. Okay. Let's see. Okay. Maybe already coming
Yes.
to the LED, proximal LED and the left main. But at that time, we should not be in a hurry to advance the retrograde macrocatheter. We must check the
Okay.
I will do antegrade IVUS check to check where is the reentry point. And okay.
So now we are
Sometimes
using.
we also could use live antegrade IVUS guidance to manipulate the retrograde wire. Okay. Okay, because we already cut off the IVUS tip of the IVUS. A little bit difficult to.
I think this makes sense because the retrograde wire seems to be moving very smoothly from the retrograde.
So this is a good sign.
Although, like Professor Li just mentioned that from the CT angiography reconstruction, it seems to be like a GCTO score 1 to 2, later. However, we can see that from antegrade approach, there is still a lot of, problem that we met because this one is very
a little
unique.
bit difficult to advance. Okay, I think enough.
Okay.
Okay.
Okay, so we can see this is a pullback from the bifurcation. Okay, we can see that the retrograde wire is joining into the main vessel. I think we are in the treatment. We can see that.
Okay.
Yes.
I think should be just as a carina.
Yes.
Okay. We could recheck the IVUS again a little bit. Okay, a little bit
Yes, we are in the
hesitation.
same, in the same
Okay.
lumen. I think the distal part of the wire we need to confirm a little bit more.
Okay.
I'll check the run.
Okay.
So the intravascular imaging usage into the CTO case, majority of the time that we use it to confirm the wire position. Okay, we can see the catheter is in the bifurcation side. As pulling back, we can see the retrograde wire is joining. You can through the occluded segment that's joining into the main vessel. And here we can see the retrograde wire is joining into the lumen that's IVUS catheter within. Here now we are in the same room. Here is the retrograde wire. And as the coming, yes, we are also in the two lumen, same lumen catheter as the proximal part of RAD.
Okay, everything is okay?
Yes, I think we are fine. Yes, in the same room. So like Professor Lee just mentioned that, yes, the tip of the wire need to manipulate a little bit because of the proximal part of RAD, there is a huge plaque burden, eccentric, huge plaque burden.
We still feel a little bit of resistance. I think we should
because
check in another view. Are you cordial? Okay. Check
because the
again.
tip, yes, the tip of the guy first seems.
Are you cordial?
Because there are two bifurcations, beneath the occluded segment. So
okay.
where, yes, should be some troublesome.
Recheck manually. Okay. Use manually. Okay. Here. Okay. IVUS. New run. Okay.
Okay. You can see.
IVUS. In the true lumen of subintimal space.
Okay, so we can see the distal wire, tip of the wire seems to be in the, yes, within the plaque we can see the distal part.
Oh, okay.
Maybe we pull back a little bit of the retrograde wire and try again.
So
the distal part is within the.
How to do next?
Yes, this is a good question. I think, for me, the anterograde seems to be a little bit difficult. Yes.
So I think we must make the wire. Okay, the reaction point should be optimal just at the carina of the bifurcation.
Yes.
But in the proximal segment,
Going
a little
up.
bit segment, maybe in the plaque, intraplaque.
Yes.
Okay.
The entry point is good.
So in such condition, I think guides are maybe helpful.
Okay. Yes. The AGT. Active greeting the retrograde wire. And also maybe helpful in control of the potential hematoma from the anterograde. So like Professor Lee just mentioned that this retrograde wire upgoing is of a little bit potential risk of going into the subintimal space because RAD is associated with a lot of important branch. So if the retrograde wire goes into the subintimal space and we use a balloon to dilate or something, that we may lose some very important set branches to cause some disasters that we do not want to see.
Oh.
And also, this is the problem of CTO with bifurcation that may cause some troublesome because there is some problem of inability for the wire, to cross the occluded segment due to the preferential gate wire entry into the patent branch and cause a failure to engage the CTO occluded segment.
2.0 balloon new one. So in order to safely advance the Godzilla,
Mm-hmm.
in most conditions, I suggest to use balloon.
To anchor the wire.
Yeah.
Mm-hmm. In this case, I think that the wire from the anti-grid in the big set branch is quite a protection to the big branch. Professor Lee, do you think that in this case, the retrograde Sasuke microcaster is a good choice or not?
Yeah, certainly Sasuke, the profile. You mean
Yes,
retrogradely?
yeah, retrograde, yes.
Certainly, retrogradely, the Sasuke also could be advanced sometimes across the collateral channel. But for this case, I prefer not to use because for the dual catheter, one limitation is to exchange the wear.
Yes.
You know,
Yes.
okay. So a little bit inflation. Okay, 10 atmosphere. Okay. Okay, down. Okay. Okay, we can see just with the help of the balloon, maybe easily advance. Okay, RAO cranial wheel, I think. Uh, RAO cranial.
As we are advancing the Godzilla catheter,
Okay,
that
careful.
as an
Okay.
extension of the gating catheter, it can active greeting the retrograde wear to reduce the risk of a potential, retrograde wear into the. Okay, I think Dr. Lee has made some
Okay.
progress. Yes, this is a fantastic demonstration. I think.
Stop. Okay.
Yes.
See. Okay.
Mm-hmm.
Use Godzilla to have the retrograde wear.
Yes.
Petition. Okay.
Although I have great confidence in Professor Lee from the manipulation of retrograde wear, but this is a wonderful demonstration, I think, to reduce the risk of distal wear into the subintimal space.
How to do next?
Okay, I think we can perform the externalization. Yes, of course, one choice. And also we can use the antigrade microcaster to, meet the retrograde wear. This is my choice.
Okay. So give me the Corsair.
Jose.
Okay, coronal wheel. Okay. Okay.
Although this is not the first time Professor Lee, make the demonstration of the 3D CTA reconstruction. Every time the Professor Lee performed this one, it struck me, a lot because the 3D reconstruction, offered a lot of very, important information of the CTO segment. For this case, it told us about the occluded segment length and also more importantly, the proximal cat position. And also, this software is interactive because you can rotate the image to check the from different angle, check the detailed information. And in our facility, under the leadership of Professor Lee, we make full use of CT angiography image to perform CT angio FFR, 3D CT reconstruction to make full use of this information. And more importantly, we possess proprietary intellectual property rights of this domestic software.
So I already advanced retrograde wear to the antigrade lumen. So commonly we could use balloon anchoring to advance the advanced retrograde microcatheter and use like RG3
Yes.
long wear,
Make
but
externalization.
very complex.
Yes.
So okay. So I think okay, I can install it there.
Mhm.
We could try rendezvous
Okay,
technique.
rendezvous. Yes.
Okay. Rendezvous technique means put the antegrade microcatheter just at the curve segment,
Hmm.
and what we could manipulate is not the microcatheter,
Hmm.
is the retrograde wire.
Hmm.
We draw a little bit.
Okay.
Okay, or I think we zoom in
Okay,
a
zoom
little
in.
bit.
Hmm.
Okay, we draw a little bit the
Okay.
retrograde wire, and no, so should advance a little bit the antegrade.
Okay.
So catheter make the tip of the antegrade catheter. Okay,
Hmm.
just at the curve of the not.
So putting their meeting point at the curve of the guiding catheter, it will
So
help us to go inside.
so okay. So if the retrograde wire couldn't be advanced, how to do next?
Okay. I think I perform externalization.
Yeah, really externalization is okay. Because if there is no other wire,
Hmm.
maybe easily
Hmm.
to advance
Hmm.
okay the retrograde wire. But as we know, there is already a wire in the diagonal branch.
Hmm.
So for the rendezvous technique, maybe a little bit difficult. It doesn't matter if
Hmm.
it doesn't work. We could try the common.
Okay, I think we make a
Okay.
success. Yes.
Okay. Alrighty, come inside.
Great
So
demonstration. Yes.
advance a little bit further to increase.
Hmm. Support of the.
Okay, increase the backup support. Talk. Okay, we will talk. Okay, at that time, zoom out. Okay.
So this can save us a lot of time compared to the externalization
But
technique.
another very important problem is if the antegrade catheter
Hmm.
could be advanced. Okay.
Okay.
Rotate a little bit. Okay, we can see.
Okay, I think we
Okay.
go through. Yes.
Okay, so at that time, must
Hmm.
pay attention. We saw a little bit to the retrograde microcatheter
Hmm.
and try not to make the antegrade microcatheter the cochlear
Hmm.
face to face to the retrograde
Hmm.
microcatheter oblong.
Hmm.
This should be dangerous.
Yes. Hmm. Yes.
Okay.
I noticed that Professor Li, the Anterograde microcatheter is Corsair Pro, right?
Yeah.
So you can make the rotation to a little bit force to go forward.
Okay. I think should be distal enough.
Yes.
Okay. We could check a little bit with retrograde. Okay. Test a little bit the RCA.
Okay.
Okay. Test a little bit. Okay. Andrew, to make the audience clearly see where is the microcatheter. Okay.
Okay.
Andrew.
Andrew. Okay.
Okay.
Okay. Good.
Okay.
Good.
Everything is good. So at that time, I think give me the cell. We draw the stiff guide wire and re-advance relatively soft wire. I think we're already success.
Yes, we make
we're already success. Okay.
95% of the procedure is finished.
Yeah. Okay.
So, Professor Li, for this case, at your first, I mean, how to say, plan for this one is from antegrade, right? So retrograde is not your, I mean, first choice for this one.
I think certainly, even we choose retrograde approach, we should make antegrade preparation.
Attempt.
So for that case, I think maybe hybrid strategy is the optimal choice.
Yes.
Okay. So at present, as we know, we have many methods and many kinds of microcatheter and wires. Okay, the success rate of recanalization is pretty high, but what we should pay attention to is the quality of the recanalization.
Yes.
Try to avoid long segment subintimal wire crossing, subintimal stent implantation, avoid set branch loss, avoid periprocedural myocardial infarction. This is what we should do. We should pay more attention. So for this purpose, the imaging guidance is very, very, very important.
Yes.
Like the software we made, the intelligent visualization system. So we already show in several cases very, very helpful. Okay. Another angle for the RC. So I think this angle is also very important to check if there is collateral perforation.
Damage.
So if there is collateral channel perforation, doesn't matter. We have the we have the Fancross microcatheter assist suture, observable suture embolization technique could easily to embolize the perforation. Another thing where so another wire into the distal LED, 2-pound barrel balloon. Okay, 2-pound barrel balloon.
I think this is of great importance for this patient because this is a relatively young male patient. And LED in the 3 vessel CTOs, LED is of the great importance because there is a lot of myocardial perfusion. It's important for the cardiac function and the future prognosis of the patient. There is a research that's published recently that the recanalization of LED CTO is associated of, over 92% overall survival after 5-year follow-up, and also increased 10% at least for the LV function of the heart. So this is of great importance for this patient, I think.
Okay, I think for this case, we already successfully recanalized the CTO lesion. And another case in the other case slide, we'll show the audience another very interesting case. The patient with a very strange calcified ring just as the ostium of the LED and the circ.
Okay.
So in that patient, Dr. Gong will show you the audience how to use intelligent visualization.
Okay, once we can see the working horsepower has been, go through to the distal part of LED.
Okay, we must sometimes we should pay attention to about the ACT. We should monitor the ACT. So for the CTO lesion PCI system is of the most importance.
Yes.
No, just hold the wire. Because I can feel a little bit resistance.
Okay.
Okay. Release. Release. Okay, a little bit rotate.
I think there is a lot of teach point in this case. We are using the, radial artery in this case, especially the left hand is a distal radial artery access, which is, benefit into the comfort of the patient and especially for the operator. And also we can see that during the procedure, first we make an anti-bleed attempt, but due to the, ambiguous proximal curve of this occluded segment, and also there are 2 bifurcations, one as a proximal entry point, the other one as a retrograde fibrous cap. So makes the antegrade parallel technique a little bit difficult. because we can see that first attempt we didn't
20.
make the antegrade very good success. However, since that the CT angiography reconstruction, we confirmed that the plaque is relatively soft fibrotic plaque. So retrograde through the septal channel relatively, easily goes upgrade from the retrograde part. And we can see Gaia first successfully penetrate the retrograde cap. Due to the previous manuscript, we understand that the distal cap of the CTO segment is majority of the time is relatively soft compared to the proximal cap because the flow flash from the antegrade, etc. So Professor Lee didn't continue to go upgrade the retrograde wire because we can see after penetrating through the distal cap, if you go up to distal, sometimes the retrograde wire goes into the subintimal space. Although, recently the intraplaque, within the vessel architecture theory is very popular. However, the proximal LED, we do not want to take risk of losing, very big set branch, even the circ. So Professor Lee stopped from the, blind upgoing of the retrograde wire, use the, the Gazilla from the antegrade to greet the retrograde wire, and finally, successfully made the retrograde wire goes into the antegrade guiding catheter. And Professor Lee performed the rendezvous technique. We can see that saves a lot of time, and also it's a very, quick procedure to push the antegrade microcatheter into the true lumen.
16.
Now that we have changed the antegrade wire to a working horse wire, and we are using the balloon to open the proximal occluded segment.
So, okay, let's see if we still have enough time to show the audience IVUS. 18, okay. Okay, 10.
So this is a 2-0 balloon, right?
Yeah, 2 balloon. Okay, done. So one key point is the two wires in the diagonal branch and the main branch should be in same layer. So that is the key point to after the main branch stent implantation.
Yes.
And the diagonal branch still patent. Okay. So okay, inflation. Okay, done. IVUS. So after the CTO lesion recanalization, we should try to avoid antegrade injection to avoid hematoma formation. IVUS, please. IVUS. And so in such condition, the IVUS track is very helpful. Okay.
The hematoma
just now the IVUS already showed the diagonal branch, very severe plaque burden.
Yes,
Yeah.
it's huge plaque burden.
Yeah.
Eccentric.
Okay.
Very huge. A little bit calcification, but not so much.
So because cut of the tip, a little bit.
Yes, maybe hard to entry.
Okay. Okay.
So Professor Lee, is this a very important, trick to cut the tip to make the blind zone?
Yeah. So I dislike this technique.
Okay.
But,
okay.
I will show the audience.
Yes.
So we can see. So after cut of the OTW segment, the crossability
reduced, right?
Reduced.
Okay.
Okay. Sometimes, but a little bit better than.
Okay. Yes, we passed
the first try. Okay. Okay. No. I
think we need to flash it. Yes.
Flash.
Okay.
Okay.
You can see we are in the true lumen from the distal part.
Relatively small size because of the no perfusion of the blood.
Yes,
okay,
shrink of the vessel.
Okay, here is severe plaque burden. So what we should pay attention is if there is myocardial bridge.
Yes.
Okay, in most conditions, in the LED proximal portion occlusion, in the middle portion, there is okay. You can introduce
Okay, so
IVUS. Okay.
yes, so we can see that seems that the set branch of the diagonal wire is drawn into the main vessel. This is a relatively very diffused, LED, a lot of plaque burden, especially at the proximal part, very concentric, fibrotic, with a little bit of calcification on the surface. So far, I think we are good. Everything is good. We are into the true lumen. A little bit hematoma, but not so much.
Yeah.
Just like Professor Li mentioned that, especially after the CTO segment has been recanalized, the distal landing zone, due to the lack of the blood perforation, the perform of the blood, that the vessel size always seems to be a little bit smaller compared to the normal segment. So this time we should pay very great attention, for the next procedure, what side of the stent and then the potential therapy that we should use. Otherwise, we may choose some relatively smaller side of the stent. So vasodilators should be applied for this kind of situation.
So most of the segment were in the true lumen.
Yes.
Yeah. So the proximal portion of the two were in same layer.
Yes, in the same room. Yeah.
Okay. So how to keep the diagonal branch patency?
I'm not quite sure, but for me, I'm not quite sure if we need to put the catheter in the DAG to make double check that the bifurcation is good.
Okay, so I think maybe we should use balloon, geode balloon technique to protect the diagonal branch.
Okay.
Okay, so a little bit natural, please.
Okay.
So because most of the segment were in the intraplaque and no severe hematoma or
No,
dissecting.
yes.
Okay, natural, please.
Natural glycerine. Natural glycerine. So, Professor Lee, do you want to use IVUS to put into the, diagonal to make a double check or not? So maybe after the balloon, we...
Yeah, I will recheck again manually.
Yes.
And I think because of the time limitation, so the live demonstration may move on to next PCI.
Okay.
So I think we're already successfully recanalized the CTO lesion.
Yes.
And Auditor Chao already gave us a wonderful close remark to show the audience all the learning points. So, but still, the optimal stent implantation also need imaging.
Yes.
Yeah, so the IVUS guidance is very important. Just now, a little bit spasm in the distal LED give some natural wait for a while. We must let the bullet fly for a while. Okay. So then check the IVUS again and check the diagonal branch again.
Yes.
Then choose the optimal standing strategy.
Yes.
Okay. So I think you could move on to the other cat side. Okay. All right.